Dr. Sharwani Mishra to coordinate the meeting and start the meeting, and make who will be there and make the judges online. If 3 seniors will be there, you just make them judges. Okay.
Thank you,
And
madam.
as another meeting, please, I may be excused.
Okay, madam. Thank you.
Thank you.
Good afternoon. We're really privileged to have our first ever clinical meet since we have our PG student since 2020. And we are really thankful to WBAP, the West Bengal Academy of Pediatrics. So Gopal Pandey, our tutor, who will introduce the speaker and we'll start the meeting. Thank you.
Hello. Hello.
Hello. Yes, sir, you are audible.
So am I visible and audible?
Yes,
Yes.
sir.
So good afternoon, everybody. Today we are organizing the WBAP 6th online clinical meeting, and this is being organized by Malda Medical College. So I'll request you, without a further delay, would please start the proceeding.
Thank you,
Okay.
sir. Sir, I
Should
would.
we start or wait for me?
Okay.
Sir, should we start or wait for Dr. Mihir?
Now start it.
Okay.
Thank you.
Thank you, sir.
First speaker, you can start.
Sir, myself, Dr. Gopal Pandey from Malda Medical College, and I would like to introduce our first speaker for today, Dr. Kushal Mandal. He is a second year PG and he will start the first case.
এই disconnect দেন। ঠিক আছে, ঠিক আছে। তুমি একদম ল্যাপটপে হাত দিয়ে দেবেন।
Sir, should I start?
Table can just. Am I
Yes,
audible?
please. Please.
Sir, am I audible?
Yeah, you are audible.
Okay. So a very good afternoon to everyone, all the faculty members. Myself, Dr. Kushal Mandal, second year pediatrics PGT of Malda Medical College. Today, I'm going to present a case, the tale of an emaciated baby. So my patient is a 2-month, 10-day-old male born out of non-consanguineous marriage from Itahar, Uttar Dinajpur, with her mother being informant, came with chief complaint of recurrent vomiting for past 1 month, respiratory difficulty for last 7 days, and unable to feed for last 5 days. According to her mother, the child was having history of vomiting which started 1 month back, which is insidious in onset and gradually progressive in nature. The vomiting is mucoid with curd-like appearance, usually occurs within 30 minutes after feed, and it is non-projectile, whitish in color, not associated with any bile or blood. Initially, it was 3 to 4 episodes, but for the last 7 days, the frequency of vomiting increases and it occurs after each feed. Mother also noticed there is gradual increase in respiratory difficulty for the last 7 days. Also, there was feeding difficulty which started for the last 5 days. Usually, the child was having nasal regurgitation of feed with vomiting after each feed. Also, there was negligible weight gain over the last 2 months, and there is no history of any loose stool. No significant major medical or surgical illness in the past. For the same reason, the child has been admitted to the local hospital and the child was managed conservatively there. And some investigations were done there, and the patient during admission bring us the report which shows an abdominal ultrasound, and it says there is thickening of the pyloric antrum, which is suggestive of with a query of pyloric stenosis. And the kidney ureter bladder region ultrasound reveals the bilateral renal raised echogenicity, which was also not very specific. From the birth history and immunization history, antenatal history of mother was uneventful, and the baby was born as a single term out of by normal vaginal delivery with birth weight of 2.6 kilogram and cried immediately after birth. Postnatal period was also uneventful, and her immunization status was up to date. In family history, the baby was the firstborn child of the family and born out of a non-consanguineous marriage. And her father and his father is 28-year-old and mother 22-year-old, and their family don't have any history of any chronic disease running in the family. The baby was start feeding on breast within first 30 minutes of birth, but it started to take formula feed with bottle from the day 21 of age. They lived in Pakka house and they belong to the upper middle class according to modified Kuswami scale. And anthropometry shows the weight of the baby is observed to be 2.7 kg, which should be expected of 5 kg according to the age. So it is less than third percentile of WHO growth standard, and also the head circumference is less. It is also less than third percentile of the WHO growth standard. Now moving on to the admission vitals, the child is active, alert. The cry good and suck is also good. Temperature recorded is 36.6 degrees Celsius and respiratory rate is 64 per minute with retraction present in subcostal, intracostal and xiphoid area. There was no grunting, but nasal flaring was there. Heart rate recorded is 138 per beats per minute and capillary blood glucose is 386 milligram per deciliter of blood. Oxygen saturation in room air was 92% and on giving oxygen with hood at 6 liter per minute, it is 98%. Now, tone is normal, and when we auscultate the baby, the chest appears to be bilateral air entry adequate with vesicular breath sound, and there is no adventitious sound. On cardiovascular examination reveals S1, S2 both heart and no any murmur heart. And parabdominal examination reveals no any obvious palpable mass and no organomegaly. So after the clinical examination and from the history, we jot down to 4 important differential diagnoses. The first of which is sepsis, second pyloric stenosis, third renal tubular acidosis, and fourth is inborn error of metabolism. So after initial stabilization of the baby, we shifted the baby to PICU, started on IV fluids, IV antibiotics as an empirical, and investigations were sent and ABG was done. So investigation report reveals the WBC count of the baby to be 19,530 per cubic millimeter with hemoglobin of 8.2 milligram per deciliter. Platelet count 5,51,000 per cubic millimeter. Peripheral blood smear shows normocytic normochromic with RBC density reduced and no abnormal cell. Serum urea is 65 milligram per deciliter. Serum creatinine 1.2 milligram per deciliter. CRP is negative. And LFT is within normal limit, and blood culture report came after 3 days, which also shows no growth. So from this report, we see that sepsis screen and the blood culture report both came to be negative. So the diagnosis of sepsis has been ruled out. After that, ultrasound of the abdomen also shows the pylorus single wall thickness to be 2.1 millimeter and canal length 13 millimeter, and stomach was not distended. So it suggests a normal pylorus, but bilateral renal pyramids are grossly echoic, which is suggestive of nephrocalcinosis. So the diagnosis of pyloric stenosis also rules out. Now, EVG was done on the day of when we shifted the patient to PICO following stabilization, and blood pH shows it's 7.03 with bicarb level of 7.1 millimole per liter and potassium level of 2.8 millimole per liter. Also, the serum electrolyte show the chloride level in the blood is 137 millimole per liter. After that, we calculate the anion gap, which turns to be 4. So our ABG reveals the patient is having metabolic acidosis, with normal anion gap with hypokalemia. So on this, we can see that the patient is goes toward the renal causes. So for that, we go for urine pH, sodium, potassium, calcium, chloride, and bicarbonate along with the other routine examination of urine. So the urine report reveals the pH is 7.0 and the urine doesn't contain any reducing substance or ketone body. Culture shows no growth and microscopic examination was also normal for urine. But the urine anion gap shows that it's a positive. It is 42.5. So from this, we can see that there is alkaline urine with positive urine anion gap in the background of metabolic acidosis with normal anion gap and hypokalemia indicates there is something in the distal renal tubule acidifying defect. Other investigations sent were the chest X-ray, which are also within normal limit, and IM panel sent, which are also normal. So from this, we can get some important findings. So in blood, we see there is metabolic acidosis with normal anion gap with hypokalemia. In urine, we see there is alkaline urine with potassium, with positive urine anion gap, and on ultrasound, we see there is nephrocalcinosis. So from this, we reached our final diagnosis that it is a case of distal renal tubular acidosis, following which we treated the child with potassium supplements, and also for acidosis, we start bicarbonate at the rate of 3 milliequivalent per kg per day. And after stabilization of the baby, we referred the child to a higher center for clinical exome sequencing. Later, the whole exome sequencing report reveals the baby is homozygous for a pathogenic variant in the ATP6 V0A4 gene, which is associated with distal renal tubular acidosis. So my take-home message from my presentation is that every child who presented to us with failure to thrive, we should look out for the chronic causes such as in GI and like renal causes, and repeated vomiting with systemic acidosis and hypokalemia usually raises suspicion of renal cause other than GI cause. This is the picture of the report of clinical exome sequencing, which reveals the genetic mutation in ATP6 V0A4 gene and distal renal tubular acidosis. So a brief about the discussion about the causes of the normal anion gap metabolic acidosis. So first, the extrarenal cause, which includes diarrhea, surgical procedures like uterosigmoidal anastomosis and pancreatic fistula. Some renal causes like renal tubular acidosis, and miscellaneous causes include iatrogenic and medications. So renal tubular acidosis is a tubular defect. It is characterized by inability of the tubule to acidify the urine that results in metabolic acidosis. Either there is defect in secretion of an acid or bicarb absorption. There are usually of 4 types. Type 1 be the distal renal tubular acidosis. Type 2 is the proximal renal tubular acidosis. Type 3 is the mixed, and type 4 being the collecting duct renal tubular acidosis. Either they are usually inherited as autosomal dominant or recessive, or they may be acquired. Usually the child present with growth retardation, polyuria, recurrent episodes of vomiting, dehydration, fever. In proximal renal tubular acidosis, mainly they associated with Fanconi syndrome, they associated with rickets, constipation, and bone pain. And treatment includes treatment of the hypokalemia first, following with the treatment of acidosis, and initial dose of alkali 2 to 3 milliequivalent per kg. And this and other complications would be addressed accordingly. This is my reference. Thank you.
Thank you, Dr. Kushal, for such a good presentation. Now we will open the house for any questions from the guests, from the delegates.
So, from where did you perform that whole genome sequencing?
Sir, we referred the child to ICH, and it was done at ICH, sir.
Okay. Okay. Got it.
So how was the child after treatment, and what will be your target? What will be the target pH, and how will you titrate the dose of bicarb?
Sir, we initially start the bicarb to 2 to 3 milliequivalent per kg per day. And as the acidosis corrected, we shall gradually reduce the dose. Initially, we may increase the dose, but after when the acidosis is corrected,
What will be the target bicarb or pH?
the target pH will be greater than 7.2.
Okay. So and how is the growth of this child? Have you just monitored the growth of the child after treatment?
Sir, yes, sir. The child came to us in follow-up. The child growth means, sir, the child came to us within 3 to 4 months after starting of treatment. The weight gain was there, sir. Weight gain was there. Initially, when we see the child growth weight was 2.7 kg. But when next time the child came to our follow-up, the child weight was around 3.4 kg. The child was gaining weight after the treatment started.
So, how long are you going to treat the baby? Because it is the renal distal tubular acidosis. It
So
is
we are-
not going to remit first. So, how long will you continue and follow up?
Sir, we have to continue follow-up up till 5 years, and we have to continue the treatment for lifelong.
Yes, that is the message that you must keep.
Yes, lifelong we have to continue the treatments.
Thank you.
There is a
Madam-
question on the chat box. Is the nephrocalcinosis, what should be the management and what would be the long-term prognosis?
Sir, nephrocalcinosis, sometimes, sir, we have to give the patient thiazide for hypercalciuria. So thiazide can be given to the patient, and if we correct the acidosis and we correct the potassium loss, then acidosis if corrected, then nephrocalcinosis will should go down, sir.
Okay. Thank you. And then another question, what about the next sibling? What is the chance of inheritance of the next sibling? Chance of recurrence.
Sir, it's an autosomal recessive. So 25%.
Yeah, so there's the genetic counseling is important for the
Yes,
parents.
sir.
So
Yes, sir. In the follow-up, sir, we also means tell the child parents that there is chance that the next sibling also get affected by this. So before, so we also done the genetic counseling, and they will take accordingly.
okay, thank you. Well presented. Thank you.
Thank you, sir.
Go to the next.
So the next speaker for today's program is Dr. Salma Parvin. She is a first year PG and she will be presenting the next case.
Good afternoon, everyone. Good afternoon, everyone. I am Salma Parvin, first year PGT, Departments of Pediatrics from Malda Medical College. I am presenting a case of anasarca and unusual etiology. In my case, patient was 11-year-old female from Bamongola, Malda, West Bengal. Present with chief complaint of fever for 2 weeks, generalized swelling for 10 days, loose stool for 10 days, and respiratory distress for 2 days. History of present illness, patient was apparently healthy 2 weeks back, then patient developed initially low-grade intermittent fever, which relieved on taking medicine. After 3 days of fever, fever became high-grade with chills and rigor. After 4 days of fever, patient developed loose stool 7 to 8 episodes per day, with not associate with mucus or blood. On the same day, swelling of whole body started, which start from lower limb and then gradually involve whole body. On the day 12 of fever, patient developed respiratory difficulty, no history of pain abdomen, vomiting, decreased urine output, no history of rash or any petechial spot. There was no significant past history, birth history uneventful, with birth weight 2.7 kg, immunization as per age. Family history was normal, no significant family history. Developmentally child was normal. Socioeconomic status of the family was upper middle class family. And anthropometry, the weight of the child was 38 kg, which was 50 to 75 percentile according to WHO growth standard, and height was 139 centimeter, which was 25 to 50 percentile according to WHO growth standard. And BMI was 19.66 kilogram per meter square, which was in normal range. On admission, the child was toxic and puffy with lethargic, temperature 103 degree Fahrenheit, pulse 136 beats per minute with regular low volume 3D pulse. Blood pressure was 104/64 millimeter Hg. Capillary blood glucose was 128 milligram per dl. Saturation 92% on room air with oxygen, or saturation was 98%. respiratory rate 40 per minute with chest retraction, and nasal flaring was also present. Pallor, icterus, cyanosis, clubbing, and lymphadenopathy was absent, but bilateral pedal edema present, which was grade 2. Chest vesicular breath sound present, but bilateral lower lobe crepitation also present. And CVS S1, S2 audible with no murmur. Per abdomen soft, distended, tender hepatomegaly. Liver was 4 centimeter from the right costal margin, and splenomegaly also present. And after following this vitals and the history, the differential diagnosis come acute leukemia, extended dengue fever, MISC, and a scrub typhus. And the day one, the course in the hospital, day 1, patient condition was poor with respiratory distress, pedal edema, and fever. So we start antibiotics, ceftriaxone, amikacin, and injection furosemide also started, and other supportive management given. An investigation sent hemoglobin, and which come hemoglobin 7.6 gram per dl, platelet come 51,000 per cubic millimeter, and Widal and MPDA test was negative. And in LFT, the serum albumin was normal, but ALT and AST are raised. AST is more raised than ALT. Electrolytes are sodium 130 millimole per liter and potassium 4.5 millimole per liter. Urea creatinine are normal in range. On day 2, patient condition deteriorated, respiratory distress increased with and patient become hypoglycemic, sensorium altered, then patient shifted to PICU. On the day 2 of hospital admission, patient CSF study was done, then cell count 0.09 per cubic millimeter, which was mainly lymphocytes, and protein 91.8 milligram per dl, and anti-SARS-CoV was 141 and CPK-MB 120 international unit per liter. And dengue IgM come negative, but USG whole abdomen show mild ascites with minimal pleural effusion. The action taken was injection furosemide and injection doxycycline was started empirically, and then IV antibiotics and other supportive management was given. On day 2, at the evening, scrub typhus IgM come positive, and echocardiography show early coronary artery changes with mild left ventricular systolic dysfunction. On the day 2, chest X-ray show also cardiomegaly with bilateral hilar congestion, and ECG show sinus tachycardia with low amplitude QRS complex. On the day 3, respiratory distress was decreased, and other investigations come normal. MRI brain was normal, and blood CS come negative. So symptomatic treatment continue as before. On the day 4, respiratory distress improved, platelet count improve, which was 110,000 per cubic millimeter, and symptomatic treatment with doxycycline continue. So in my case, final diagnosis was patient diagnosed as a case of scrub typhus complicated with heart failure with altered liver function and massive pedal edema. So we have to keep in mind about scrub typhus in a febrile child with multi-organ dysfunction syndrome. So from the start, we should give the patient doxycycline empirically, should not wait for the report. Early treatment with doxycycline can prevent serious life-threatening complications of scrub typhus. Scrub typhus is a rickettsial disease caused by Orientia sushugamushi, which usually leads to features of fever, rash, ester, and in case where early treatment is not instituted, complications, scrub myocarditis, scrub encephalitis, and liver dysfunctions, and acute kidney injury can occur. This is my reference.
Thank you,
Thank you.
Salma, for the presentation. Now, we would like to request the house for any questions that can be asked to her.
Have you
Hello,
done
I
the
joined
MRI?
just now.
Have you done the
Hello, there
MRI?
Yeah, 2 questions are there in the chat box. Dr. Shakun, please continue. Please go on.
So have
Carry
you
on,
done
carry
the MRI?
Is there any question? Or we should carry on to next speaker?
No. There are a lot of questions there. Dr. Basudev Patra has asked whether there was any ecchymosis of the petechiae on the buttocks.
No, sir. There was no ester or no ecchymosis in the buttock. And no skin rash also detected.
So what are the systems that get involved in the scalp typhus?
What are the systems that get involved?
So, scalp typhus involve mainly vascular system, then heart, lungs, kidney, liver. This is multi-system involvement can occur in.
So you have written the encephalitis. Have you done the MRI brain?
Yes, sir. MRI brain we have done, and it was no abnormality detected in MRI.
Okay. So there was other question, I think. So the INR value and the leptoserology defect, if you have done, which is the better drug, Agitro or Doxy?
Doxycycline, sir.
Okay. Have you done this? Have you done this leptoserology? Because it is a particularly in this monsoon period, leptospira icterhemorrhagica must be ruled out. So have you done the leptospira, Matt?
Sir, it's not available in our hospital, so we cannot do this investigation.
So dengue report
Dr.
came.
Pandey, we can
That's why
go, we have
didn't
covered
proceed. Sorry, the scrub report came positive and leptospira is not available in our hospital setup. We have to send it privately. So it didn't proceed further.
No, there are a lot of papers that the leptospira and the scalp typhus goes hand in hand.
Right.
So it would be available. So what the audience has asked that could be done. Anyway, Dr. Pandey, we can move on to the next case. We have covered almost all the questions.
Okay.
Thank you, sir.
Sir, our next speaker is Dr. Manorika. She is a first year PG and she will be presenting the next case.
A very warm good afternoon to one and all present. I am Dr. Monorika, first year PGT, and my case is about a complicated case of anemia. My patient is a 6 years old female who is the firstborn child out of non-consanguineous marriage of a Hindu family hailing from Shahpur, Malda. The informant was mother, and the child presented to us with fever for last 4 days, reddish discoloration of urine and paleness of whole body for last 2 days, and yellowish discoloration of eyes for last 2 days. History of present illness, the child was apparently normal 4 days back, after which she developed fever, which was high grade, intermittent in nature, not associated with chills or rigor, and relieved on medication. There was history of red colored urine and paleness of whole body for 2 days, and history of yellowish discoloration of eyes for 2 days. There was no history of trauma, any drug intake, burning micturition, increase in frequency of micturition, melena or pale colored stools, joint pain, rash, vomiting, pain abdomen, altered sensorium, any bleeding manifestations or respiratory distress. Past history, there was no history of similar complaints in the past or any surgeries in the past. Birth history, the antenatal period was uneventful and there was no history of jaundice in the neonatal period. There was no history of NICU admission and the child is immunized up to date. Family history, the child was the firstborn child of the family and born out of non-consanguineous marriage. There was no history of any chronic diseases or hereditary disorders in the family. Dietary history, the child takes adequate calories and protein for the age, and the family belongs to upper middle class. Anthropometry, the height of the child was 110 centimeters, which falls between the 15th and 50th percentile according to WHO growth chart. And the weight of the child was 17 kgs, which falls between the 15th and 50th percentile according to the WHO growth chart. Examination on admission, the child was lethargic. The heart rate was 138 per minute. Saturation was 94% in room air. The blood pressure was 100 by 60 millimeters of mercury. Temperature was 102 degree Fahrenheit. Respiratory rate was 32 per minute. The capillary blood glucose was 116 milligrams per deciliter. There was pallor and icterus present. There was no cyanosis, clubbing, edema, and lymphadenopathy. On auscultation, bilateral air entry was adequate and vesicular breath sounds were heard. There were no adventitious sounds. On cardiovascular system, S1, S2 was heard and there was no murmur. Parabdomen examination, hepatomegaly was present. The liver was palpable up to 5 centimeters below right costal margin, non-tender with a smooth surface, and the liver span was 12 centimeters. Spleen was not palpable. So the differential diagnoses that were kept in mind were malaria, leptospirosis, viral hepatitis, hemolytic anemia, post-streptococcal glomerulonephritis, SLE, and G6PD deficiency. Course in the hospital, on day 1, malaria rapid antigen test was done and found to be negative. The child was put on IV fluids, IV antibiotics, and other supportive management. On day 2, fever spikes were present. Child was still lethargic and few special investigations were done. On day 3, the child was not so lethargic, active and alert. Fever spikes decreased and 1 unit of PRBC was given. Investigations. Complete blood count showed leukocytosis with WBC at 21.4 thousand per cubic millimeter. RBC was 1.1 million per cubic millimeter. Hemoglobin was 4.2 gram per deciliter. Platelet was 2.87 lakhs per cubic millimeter. MCV was 88.2 femtoliters. MCH was 38.2 picogram and MCHC was 27.6 gram per deciliter. On peripheral blood smear, the RBC picture was normocytic normochromic along with anisocytosis, and there were 8 nucleated RBCs per 100 WBCs. WBC showed leukocytosis with mild shift to left. There were no blast cells seen, and platelets were adequate. The LDH was raised. It was 463 international units per liter, and ESR was 25 millimeter at the first hour. Reticulocyte count was 5%, and the corrected reticulocyte count is 2.6%. CRP came to be reactive, and MPDA, Vidal, dengue IgM, scrub typhus IgM, and leptospira IgM was negative. Serum urea and creat were normal. LFT showed indirect bilirubin as 2 milligram per deciliter, and albumin was low, 2.2 gram per deciliter, and ALT and AST were raised. PT was 30 seconds, and INR was 2.2. APTT was normal, and serum electrolytes were normal. So the viral markers that were done, anti-HAV, anti-HEV, and anti-HCV, all came to be non-reactive. Direct Coombs test was negative, and G6PD value was also normal. Urine REME showed cola-colored urine and protein in blood in trace amounts, with pus cells 2 to 3 per high power field and RBCs 2 to 4 per high power field. And USG whole abdomen showed hepatomegaly with diffusely thickened gallbladder wall, and chest X-ray was normal. So our provisional diagnosis was hemolytic anemia in a case of SLE or Wilson's disease. And then we sent few special investigations like serum ceruloplasmin, ANA profile, eye examination was done, and 24-hour urine copper was sent. On day 4, the supportive management was continued and the ANA profile report came as negative. So the diagnosis of SLE was ruled out and serum ceruloplasmin value was low. So eye examination was performed to see for features of Wilson's disease like KF ring and sunflower cataract, but these features were not found. And the urine is no more reddish. The urine turned yellowish in color, and urine copper, 24 hours urine copper came out to be 450 micrograms per day. So our final diagnosis was hemolytic anemia in a case of Wilson's disease, first presentation. Discussion: Wilson's disease is an autosomal recessive condition caused by a mutation in the Wilson disease protein, ATP7B gene. And diagnosis is difficult and involves blood tests, urine tests, and liver biopsy, along with thorough clinical evaluation. And genetic testing should also be performed in siblings of those who are affected. And the defect is located on the long arm of chromosome 13q, which has shown to alter the copper transporting ATP gene in the liver. The majority of patients with Wilson's disease present within the first decade of life with liver dysfunction. Neuropsychiatric features are usually seen in the second or third decade. And if Wilson's disease is rare, but if not treated, can be fatal. And so liver function tests are deranged with elevated AST and ALT levels. And if there's suspicion of Wilson's disease, then we should definitely do a ceruloplasmin level. It will be less than 20 milligrams per deciliter. and urine copper levels more than 100 micrograms per deciliter per day are significant for Wilson's disease. And these two lab findings along with KF rings are usually enough for diagnosis. But if we suspect any alternate diagnosis, then we should perform a liver biopsy to check for liver copper levels. And a positive result is copper level greater than 250 micrograms per gram of dry liver tissue. And if we suspect any brain involvement, then we should do an MRI also. The take-home message is hemolytic anemia may be associated with chronic liver disease like Wilson's disease. So a thorough workup should be done to look for Wilson's disease so that the diagnosis is not missed. These are my references. Thank you.
Thank you, Manorika, for the presentation. Now, any questions from the audience?
What is the bedside test that you can do in a case of Wilson? And was there any subtle clinical features suggesting of Wilson's disease?
So bedside, we can look for features of liver
No,
dysfunction.
bedside test.
Bedside test.
You can go see the basophilic stippling. When it's done, and was there any subtle features of Wilson's disease?
No, sir, the child didn't have any such features which will point out towards Wilson's disease from the beginning. Like there was no neuropsychiatric manifestations, and the hepatic dysfunction was also not so prominent.
So any sleep alternation or any scholastic performance, bad scholastic performance?
No, sir, the child was not having any deterioration in scholastic performance or any tremors or anything. No such features were there.
There was a question, how do you manage the Wilson's disease? And he has suggested actually the triantine and the zinc in the management. And you know, we are not concerned about the management. So these are given. How will you differentiate autoimmune hemolytic anemia in this case, apart from direct Coombs test? So have you done any other test to see the autoimmune phenomenon? You have written the DCT is negative, and you have done all the HEP2 also, no?
Yes, sir, lepto is also negative.
But Dr. Mishra, you told in Malda you don't do the leptospira. But in our presentation, I have seen the leptospira has been done.
No, it is not possible from our institution. You have to send to our side, Sonoscan or like that, private laboratory. That's
Okay,
right.
but here she has done this.
This time it was done.
Okay, nice case. So, Dr. Pandey, we may go on to the next case.
Okay, thank you, sir. Sir, the next speaker is Dr. Riya Datto. She is first year PG and she will be presenting the next case.
Good afternoon, everyone. I am Dr. Riya Datto, first year PGT of Department of Pediatrics, Malda Medical College. The topic of my case is splenomegaly, a diagnostic dilemma. My patient, an 11-year, 10-month-old male hailing from Jalalpur, Manikchowk, Malda. Date of admission was 21/6/2023 and date of examination was on the same day. Informant was both child and mother. The child was a firstborn child out of non-consanguineous marriage. The child presented with chief complaints of abdominal distension for 6 days, fever for 4 days, red urine for 2 days, and swelling of both legs for 2 days. My patient presented with complaints of abdominal distension, which was noticed 6 days back, associated with high-grade intermittent fever, which was for the last 4 days, which was not associated with chills and rigor. There was red-colored urine for the last 2 days and swelling of both feet for the same duration. There was no history of loose stool, vomiting, no history of convulsions, respiratory distress or generalized body ache, no history of any recent hospitalizations. History of past illness, no significant major past illness in the past, no significant family history, and immunization status completed as per schedule. On admission, the child was alert, conscious, but toxic looking. SpO2, 94% in room air, pulse rate 138 beats per minute, regular but slightly high volume. The child was febrile and the temperature was 102.7 degree Fahrenheit. The respiratory rate was 27 per minute and was regular. CVS was S1, S2 audible with no murmur. Chest, bilateral, vesicular breath sounds positive with equal air entry in both lung fields. No added or adventitious sounds were present. The blood pressure was 127 by 72 millimeters of mercury between 50th to 90th percentile. Per abdomen soft, diffuse tenderness all over abdomen and splenomegaly, which was 4 centimeters from the left costal margin present. Anthropometry, the weight was 32 kg and the expected weight is 39.9 kg and the weight falls between 25th to 50th percentile of the WHO growth chart. Height was 146 centimeter, which was between 10th to 25th percentile. BMI 15.01 kg per meter square, which also falls between 10th to 25th percentile. After the admission findings and the clinical features, we come to a differential diagnosis of malaria, G6PD deficiency, post-streptococcal glomerulonephritis, UTI, and scrub typhus. Relevant investigations that were done: malaria rapid antigen test kit was negative for both Vivax and falciparum, which was done on day 1. Complete blood count, WBC was 25,470 per cubic millimeters of blood. Hemoglobin was 11.3 grams per DL, but platelet was decreased 83,000 cubic millimeter of blood. Liver function test was within normal limits. Urine routine and microscopic, pus cells plenty, epithelial cells plenty, and RBCs plenty per high power field. Renal function test, serum urea was increased 90 milligrams per DL and serum creatinine was borderline increased 1.6 milligrams per DL. Serum complement C3 was sent and it was 79 milligrams per DL. Normal range is 90 to 180 milligrams per DL. G6PD was 11.6 units per gram of hemoglobin. Normal 4 to 13 units per gram of hemoglobin. MPDA, Vidal, dengue IgM, scrub typhus IgM, and RK39 antigen was negative. HPLC was also done, which showed normal hemoglobin. The USG of whole abdomen shows splenomegaly, both kidneys hypoechoic and slightly globular, suggestive of bilateral pyelonephritis, right greater than left. Pelvic ileal system was not dilated. So our provisional diagnosis after the investigations was complicated UTI with splenomegaly. The course in the hospital. The child was being treated in the lines of complicated UTI, but the splenomegaly was the cause of all the dilemma. Amidst this, on day 4 of admission, the child had 3 episodes of hematemesis. Urgent USG with color Doppler was done, and it showed splenomegaly, cavernous transformation of portal vein, pericholecystic collaterals. These were the features suggestive of extrahepatic portal vein obstruction. Further detailed history revealed umbilical sepsis in neonatal life. Octreotide infusion was given for 24 hours and hematemesis ceased. Later, upper GI endoscopy was done and it showed esophageal varices. So our final diagnosis was extrahepatic portal vein obstruction with pyelonephritis. Conclusion: high-grade fever associated with splenomegaly is usually caused due to malaria, Kala-Azar, or scrub typhus, which is common in our area. Also, thalassemia is very common in our area. So to rule out, we did an HPLC, which was also normal. We should be vigilant enough and not neglect an unexplained splenomegaly until cause is found. Extrahepatic portal vein obstruction is a leading cause of portal hypertension in children, giving rise to upper and lower GI bleeds, and is a major cause of morbidity in young children. The most common causes of portal vein obstruction can be from a direct injury, that is like omphalitis, umbilical catheterization, neonatal peritonitis, abdominal trauma, surgical trauma, cysts and tumors, portal vein abnormalities like stenosis, atresia, and agenesis, indirect causes like neonatal sepsis, dehydration, multiple exchange transfusions, hypercoagulable states, and can be also idiopathic. These are my references.
Thank you, Dr. Riya, for the presentation. And now I would like to request the audience if they have any questions from Dr. Riya on the case.
No questions so far, only the praise. Okay.
Yes.
Thank you for the nice case. We can move on to the next.
Okay, thank you. Thank you, sir. Our next speaker will be Dr. Shrestha C. She is a first year PG and she will be presenting an interesting case. This is the last case of today. The journey of a child with pyrexia.
Good afternoon, everyone. Myself, Dr. Shrestha C. Today, I am presenting the case, the journey of a child with pyrexia. So, my patient, a 3-year-old male child, born out of non-consensual marriage from Shershahi, Malda, West Bengal, informant cough and cold for last 15 days, fever for last 8 days, bilateral red eyes for last 5 days, and bleeding from nose and mouth for last 3 days. According to informant, child was apparently well 15 days back. Then he developed cough and cold associated with fever for last 8 days, which was high grade, intermittent, partially relieved on medication, and more in night. He also had congestion of bilateral eyes for last 5 days. Informant also complaining of bleeding from bilateral nostril and mouth for last 3 days, which happened 3 to 5 episodes per day. From last 3 days, he was having decreased oral intake, no history of chills and rigor, burning micturition, yellowish discoloration of skin, rashes, ear discharge, vomiting, altered sensorium, itching of eye, or difficulty in vision. No history of similar episode or any major illness in past. Birth history was uneventful. Child was completely immunized for age as per NIS schedule. Child attained all milestones as per age, and baby is now with normal familial diet. Family history also nothing significant. Family history found. Personal history was also normal. So on general examination, child was found conscious, irritable, toxic looking. On examination of eyes, bilateral congestion seen. On examination of neck, bilateral multiple cervical lymph node palpable. Node number on right side more than left side, and maximum diameter 2 cm by 1 cm. And those were tender, discrete, firm, not fixed to underlying structure, freely movable, and overlying skin was normal. On anthropometric parameter, height was found 94 cm, which falls between 15th through 50th percentile. Weight found 13 kg, which also falls between 15th through 50th percentile. And mid upper arm circumference was 14 cm, which falls between 15th through 50th percentile. Vital patient was febrile at the time, and temperature recorded 102.5 degree Fahrenheit. Pulse rate was 102 per minute, which was regular, normal volume, or peripheral pulses palpable. Respiration rate was 36 per minute regular. BP was recorded at right upper lip and measured 95 by 65 millimeter of mercury, and SpO2 was 98% at room air. On respiratory system examination, bilateral ARND present. CV examination H1, H2 had no added sound. CNS examination, child was found irritable, no meningeal sign recorded. On GI system examination, soft, non-tender, abdomen palpable, and no organomegaly. On reticular endothelial system examination, bilateral multiple cervical lymph node palpable, and maximum diameter 2 cm by 1 cm. So with this history and clinical feature, we came to a differential diagnosis of adenovirus, acute leukemia, dengue fever, incomplete Kawasaki disease. Course in the hospital on day 1, that was the day 9 of illness. Child was irritable, fever spike present, bilateral congestion of eyes with frontal headache present, and epistaxis ongoing. So we sent our all blood investigation along with urine investigation and chest X-ray, and broad spectrum and IV antibiotics started along with other supportive care given. Opinion taken from eye and ENT department. On day 2, that was day 10 of illness, fever and epistaxis persisting, 2 episodes happens per day, and CBC report was normal, PVS was also normal, CRP was reactive more than 2.4, ESR was 24 millimeter per first hour, MPD scrub typhus, dengue IgM, Vidal came negative, urine REME showed partial 15 to 20 per high power field, PT APTT INR was normal, USC whole abdomen, no abdomen detected. Chest X-ray also was within normal limit, and we did CT PNS. So we antibiotics were continued. On day 3, that was day 11 of illness, fever and epistaxis present. CBC report shows leukocytosis, hemoglobin levels falls. Platelet was 263,000 per millimeter cube. CRP was reactive 2.4. ESR was increasing 40 millimeter at first hour. CCT PNS result shows bilateral maxillary and ethmoid sinusitis, nasal septum deviated towards left. Urine culture sensitivity and blood culture sensitivity report came negative. On day 4, that was day 12 of illness, high-grade intermittent fever persisting. CBC reports of WBC 15,900 per millimeter cube, hemoglobin level 9.5 gram per DL, platelet was increasing 478,000 per millimeter cube. CRP and ESR was also increasing. CRP was 5.1 and ESR was 80 millimeter per first hour. Serum albumin level was low, that was 2.8 gram per DL. We sent serum ferritin and D-dimer report, and we continued our previous management. On day 5, that was day 12 of illness, fever on and off type, and child was found irritable. And CBC report shows hemoglobin 9.9 gram per DL, and platelet was 580,000, which drastically increased. CRP was 6.7 and ESR was also increasing 86 millimeter at first hour. D-dimer and ferritin report was normal. So with this laboratory investigation, we came to our diagnosis incomplete Kawasaki disease, and we sent 2D echocardiography report, and we shows LAD Z-score of left anterior descending artery 2.56. In the meantime, viral panel also came negative. So we started IVIG 2 gram per kg along with low dose of aspirin 4 milligram per kg per day. On day 6, that was day 14 of illness, fever decreased, single episode of epistaxis happened, and we continued our previous management. On day 7, that was day 15 of illness, fever and epistaxis subsided and general condition of baby improved, and CBC report gets normalized. So from this picture, our final diagnosis was incomplete Kawasaki disease. Kawasaki disease in an acute febrile illness of early childhood characterized by medium vessel vasculitis. As presentation of Kawasaki disease is similar ongoing adenovirus epidemic, as early diagnosis and prompt treatment can decrease, which is a dreaded complication of the diagnosis was delayed and it was associated with epistaxis, which is not a common clinical feature in Kawasaki disease and thus mislead us. To evaluate the incomplete Kawasaki disease, children should have fever more than 5 days along with 2 or 3 compatible clinical criteria, and CRP more than equal to 3 milligram per DL and or ESR more than equal to 40 millimeter per hour, along with 3 or more laboratory finding, anemia for age, platelet count more than 450,000 after the 7th day of fever, albumin less than equal to 3 gram per DL, elevated ALT level, WBC count of more than 15,000 per millimeter cube, urine more than equal to 10 WBC per high power field, or positive echocardiogram. These are my reference. Thank you.
Thank you, Dr. Sestra, for the presentation. And now we would like to invite questions from the audience, if there are any.
Yes, so very good presentation. Just I want to know that whether any sample, the nasopharyngeal swab sent for bacterial culture for as the patient has ethmoid sinusitis, so streptococcal infection on the tap may be there associated with it. So was that same for this patient? Also, the Epstein-Barr virus can have the similar presentation with the lymphadenopathy, persistent fever. Then that can also have associated with the dilated coronary. So that is the one question. And the why did you take the already patient had 8 days of fever with red eyes and lymphadenopathy? Why did you take 5 days to do the echocardiography to be done?
Sir, actually these cases complicated with epistaxis. So we think this may be a case of sinusitis. That's why patient was bleeding. But on the subsequent days, the thrombocytosis was present in the CBC report. And along with that, echocardiography facility is not present in our hospital. So we did it from outside. So 5 days time taken.
Sir, after stabilization of the patient
Can you please stop sharing? Can you please stop sharing? So actually in the urine report, it was seen there was steroid pyuria.
Yes, sir.
And what was the sodium level, serum sodium level?
Serum sodium levels are normal. It was 141 millimole per liter.
Hyponatremia, that was the another clue. So atypical Kawasaki, yes, that is the diagnosis, and gradually increasing platelets and ESR. That
Yes.
should be the other clue. But I cannot explain that epistaxis with sinusitis. So I have not seen any case of the Kawasaki disease with the epistaxis.
Sir, in
So
this
how common it
CTP
is? How common it is? Yeah, you have searched the literature, no? How common
Sir,
it is? This
I didn't
association
found
of
any case.
sinusitis.
I didn't found, sir, any case, but sir, in CTPNS there is maxillary and ethmoid sinusitis along with deviated nasal septum. This may be a cause of epistaxis in this child.
Say it may be coincidence.
Along with, sir, he had fever, so that epistaxis may be ongoing.
Okay. So our president ma'am has joined, Professor Kalpana Datta. So I request Dr. Datta to pitch in.
Thank you. Yes, madam.
Yeah. Thank you, Dr. Roy, and nice presentations. All the presenters have done the right job to present the cases, and the nicely selected cases also. Nice mentoring also. And I think like you asked the question about the sinusitis and epistaxis, that may be due to the viral infection, which led to the incomplete Kawasaki. Usually have a fever. We don't know what virus can cause. So fever is there. There's something is there for the fever, and that may cause sinusitis and bleeding also. May not be directly related with the Kawasaki also. So thank you all. If there's any other questions, others they can ask. So from my side, this much of input is there. This is very good cases and nice
I
presentations. All.
must congratulate the whole team. All
We
the
present from beginning.
maximum first year student has presented their cases.
Because
So I
second
thank
that
the
is
mentors.
that is the wonderful thing.
second year,
we
is
must
in
appreciate
Balughat.
them.
That's why first years were available.
Yeah, and a big applause for them. This is a big applause for them because the first years they have done a very wonderful job. So we are really
Commendable.
proud of them. And it's very nice to see this academic all over West Bengal. There's a Pan Bengal.
HOD had OPD today and SC joined now.
Ma'am. Thank you, ma'am, for including us, that Malda Medical College Department of Pediatrics in IEP clinical meet for the first time. Thank you, West Bengal IEP. Thank you very much.
We want to reach to all, Sushma. We want to reach to all. And at the end of the meeting, I'm just inviting you all to just attend the workshop on the DSC workshop happening in Kishanganj Medical College. So it is just 2 or 3 hours journey from your place. So I have sent Dr. Sushma the form. So if you are willing, may please join. And it is, I am assuring, it is a very informative and a very good workshop.
Okay.
Developmentally supported.
As you are teacher of education, you must invite them also to join. Is going to help.
Madam, you are not audible.
Madam, your voice is breaking.
Scanning speech ho raha hai, madam.
I'm not audible.
You're now audible.
Now audible.
Acha. Actually, my name is Anustal. My name is I'm towards a garden ditch due to some meeting and all. So I'm coming from that. So the academic activities which are going on under the flagship of WAP. So please join all the workshop, Pathshala or clinical meeting, whatever. I invite you all and make it a grand success. Thank you.
Thank you.
So Dr. Me, should we conclude? So make the concluding comment. And thanks to the mentors, Dr. Gopal Pandey and Dr. Sharbani Mishra. Me, please conclude.
Thank you. On behalf of Malda Medical President, we conclude. Thanks.
Yes, so many congratulations to all the PGTs who have presented. Being a first year, they have presented excellently. So, and it was well worked up cases. And also the thanks for all the mentors and the team Malda Medical College, and very good to see all of you. And I think that there is a very good number of participation also. There's 35 joined in the from the Zoom link. So normally in the physical meeting, we don't have not more than 10, maximum 10 to 12 participants from the other institute, besides the normal the institute who are presenting. So very good to see that. So the many people are joining in the Zoom link also. So again, thank you to the Malda team, and thank you the organizers and the West Bengal Academy of Pediatrics. Now we can conclude. There are many programs will be coming in the later on in the West Bengal IIT. Next is the asthma con is there. There will be simulation national conference will be there. Then our West Bengal Pedicon will be in the month of December, second week of December, 8th, 9th, and 10th. Because the PGTs will get chance to represent their work in a paper presentation. Also, there will be a lot of workshops on the 8th of December, and 9th and 10th there will be conference in Kolkata. So request you all to join in West Bengal Pedicon in the month of December, second week. Thank you.
Thank you, sir.